Anemia. So what are your symptoms of anemia? So your RBCs do what again? They carry oxygen, right? And they carry CO2 away from tissues. You don't usually get symptoms of CO2 buildup, but you do get symptoms of O2, poor O2 delivery, right? O2 deficits. So there's an O2 deficit of the tissues. They don't know if it was because of a low hemoglobin or a low PO2 or a low cardiac output. They have no idea. So that was our arterial content of oxygen that we talked about, right? All the tissues care about is that they are not getting a delivery that they expect, right? They expect a delivery of about 600 mLs per minute of oxygen stuff, right? And that could be affected by cardiac output. That could be affected by the arterial content of oxygen, or CO2. So it could be the O2 saturation of the RBCs. It could be the PO2 that's in the blood itself. And it could also be the hemoglobin, right? So we talked about all kinds of reasons why you'd have low RBCs due to low hemoglobin because of iron deficiency or low RBCs in general. Either way, we have low RBCs that are not delivering enough oxygen. Therefore, we have dyspnea on exertion. So someone's trying to exert themselves and they get dyspneic because they ran out of oxygen. The O2 delivery was not enough. Okay, so dyspnea on exertion or at rest. Obviously, at rest is a lot worse, right? When it just happens all of a sudden at rest, that is they start getting short of breath. That's someone who's severely anemic. And usually these patients don't have anything else going on in their lungs. So if someone has dyspnea on exertion, you're like, oh, do you got crackles? Oh, do you have bronchoconstriction from asthma? Oh, do you have sputum production like a COPD? Or oh, do you have, those are usually, or like a pneumothorax? Is that what's going on? So, but these guys don't have anything else going on. They are just anemic. That's the reason why they have dyspnea on exertion. And a quick note is that, ICU patients usually have other stuff going on. People don't usually get admitted to the ICU with iron deficient anemia. They'll get admitted to Med-Surg 2, Med-Surg 3 with that, but not to ICU. So usually you can't always say the lung sounds will be clear. They might have a pneumonia that really kind of pushed that anemic patient over the edge. Okay, and we talked about SNS response, right? O2 stimulates the SNS, so does low blood sugar, so does low blood pressure. All these things stimulate the SNS to get the SNS firing off to try to fix the problem. So how's the SNS going to fix the problem when your oxygen is low? SNS stimulates erythropoietin. So that makes sense, right? So if we want to get more RBCs in circulation, we're going to have more, we need more erythropoietin, and SNS does that. Okay, so the response to hypoxia, try to breathe faster, get more oxygen in. That's going to help, hopefully. And SNS is going to keep firing off, and it's going to actually make your heart work extra hard, right? And for a prolonged period of time, because it's the oxygen is low, and it's not getting fixed by breathing faster. It's not getting fixed by EPO, because EPO could be released, but if you don't have the building blocks with iron, B12, or folate, or you have sickle cell disease where you're hemolyzing everything, that more SNS and more EPO is not going to fix the problem, right? So the heart can actually be overworked to the point where you get a hyperdynamic cardiac output. So when they throw an ultrasound on the chest, it's like the heart's beating super, super hard, super fast. The cardiac output is not 5 to 8 anymore. It's like 10 to 12. It's a ridiculous cardiac output, right? Because the SNS is in a hyperdynamic state, right? And what can that lead to? Yeah, right, an MI, right? So an MI is a complication of an anemic patient, right? People don't die of dyspnea on exertion. That's not a thing, right? But people die of a MI because the oxygen wasn't enough to the tissues itself. We just increased the O2 demand of the heart, and now we already have low O2 to our myocardium. So that could put us at risk for a myocardial infarction, okay? And that's called a high output failure. Heart's working fine. It wasn't like a low output failure where I had like a heart failure and a lack of flow of shock state that caused me to get a MI or a CAD of my coronaries and caused a lack of flow. It was a lack of oxygen delivery to my myocardium. That was actually working harder because of our own doing. Okay, and that happens at a hemoglobin less than 5. So usually 5 all the time needs to be fixed. That's not a thing where you can just say, oh, that's okay, let's do another check. All right, hemoglobin less than 5 is a high risk for MIs. Okay, so what else? People get fatigued and weak because your muscles aren't getting oxygen, and they get pale and pallorous because there's not RBCs to give you your color of your redness, right? And they then become syncopal, right? So syncopal and the pass out, and you don't die of syncope. No one has died of syncope, but people get syncopal and they drive in oncoming traffic, or people get syncopal and they fall over and hit their head, right? So that is going to cause problems, okay? So they'll get lightheaded, they might get confused, they might get brain fog, they might go long and long with the respiratory lectures. We don't know what's going on. All right, so specifics. So specific anemias have specific symptoms because these are very generalized. That's going to happen with every anemia ever. So specific things, B12 is for nuclei, especially nuclei of the nerves. So we're going to have nerve symptoms and nerve damage with B12 deficiency, and it's like permanent. It's not something you can like bounce back from. So you got permanent nerve problem like paresthesias and such. Hemolysis, they're going to have buildup of bili. They're going to have what haptoglobin changes? What are our hemolysis labs again? Haptoglobin will go up or down? Down. It'll go down. So our labs, low haptoglobin. Everything else is up, right? LDH, reticulocytes, T bili, those are all up. Its haptoglobin's going down because it's sopping up all the extra heme that's being put into circulation. Our macrophage was eating all the RBCs, and it needs to get conjugated in the liver, but the extra haptoglobin in there, it's going to start going down, right? So not a picture there actually is haptoglobin, so put H's, right? So H's are bind with all the heme. I missed it, right? So there's all the heme there. Those are all getting used, and then our haptoglobin is going to go down because bind with all the heme. But the bilirubin is going to go up, and if our RBCs are breaking down, they release what? They release LDH as well. All right, so LDH goes up, haptoglobin goes down, bilirubin is going to definitely go up, right? And specifically, it's the unconjugated. So we got an unconjugated here, and over here we have the conjugated, right? So conjugated, unconjugated. Doesn't make sense when I see the same direction as my V, or my U. All right, so yeah, so C is going to be this way, right? There we go. Conjugated, unconjugated, so uncon, right? So we have buildup of unconjugated bilirubin. That thing is fat soluble, so it's going to go anywhere once. It's going to go to the eyes and cause icteric sclera. It's going to go to the skin and cause icterus. It's going to go to the, if it is enough, it can actually cause change in stool color. But really that happens when you have like a coli problem, so it's not always common. But what you definitely will get is tea-colored urine, which I don't think is up there. So let's put tea-colored, right? So tea-colored will definitely happen with someone that has a hemolysis problem, an elevated in bilirubin. Who else elevates bilirubin? Our liver patients, hepatitis patients, our bili patients, but this is another reason why we might have an elevated bilirubin. Those are like the really three primary reasons we would have a elevated bili, okay? But you can tell if it's liver, gallbladder, or hemolysis based on whether it's conjugated or unconjugated. Because of a liver problem, it's actually able to conjugate. So it's still, that process still works in cirrhosis, believe it or not. All right, it's like that's the one they said. So that's the one you're gonna keep. That's the process, not the ammonia BUN process. It was the conjugation process. I mean, I can tolerate yellow skin. Yellow skin is not going to cause, it isn't life-threatening. Okay. Well, actually, if it gets too high, like T bili, that's more than 20, usually starts causing neuro changes, like with your babies, right, with hemolysis and such. That's usually unconjugated bilirubin. Anyways, again, distracted. Either way, you got B12, hemolysis, and then we have iron deficiency has this unique symptom of pica. What is pica? Eating random crap, right? So pica. So phaging inappropriate crap all the time, right? So pica, I don't know. So you have pica is you're eating ice all the time. They're chewing on paper. They're eating things that are that don't ironically have iron, but it's something that they might be chewing on dirt. Dirt has iron, but so that these are things that are unique to someone that has iron deficiency anemia. You always know who it is. It's someone on night shift. They got a cup of ice all the time, and they're always chewing the ice all the time. What are you doing? Oh, I just like ice. No, you got iron deficiency anemia. That's what happened. That's what's going on. So we got pica, and then other signs, you might get splenomegaly, coagulopathies, especially the liver is involved. You start congesting those systems. If we talk about the life-threatening stuff, you'll go faint, get syncopal, and that will lead to a fall of some sort, right? Or a trauma of some sort. And then you could get an MI as a critical complication of anemia. Okay, so what's the fix? The fix is the underlying problem. That's the answer. So if they have iron deficiency or folate deficiency or B12 deficiency, give them B12, folate, or iron. And these last two do great with vitamin C. So get some vitamin C in there too, right? That's going to potentiate iron absorption for like 7x or something, 4 to 7x. It's going to really absorb it well from the GI tract, right? And just a note, PPIs, they're great, but they actually inhibit B12 absorption, so that's not great. So we got to make sure that if they have B12 deficient anemia, we should maybe not choose pantoprazole. We maybe choose like cimetidine, for instance, or famotidine. Cimetadine's off the market, isn't it? Anyways, we have erythropoietin. If they're short on EPO, give them EPO. We don't give EPO for the hemoglobin greater than 11, because then you're going to make too much RBCs and you're going to have problems of polycythemia. Okay. We talked about blood transfusion targets. 7 is where it's at. And specifically CKD patients, they're at risk of this increased hepcidin hormone, which is a problem. It actually inhibits iron absorption. And so we talked about it briefly in anemia of kidney disease. And it's, inflammation causes hepcidin, CKD causes inflammation, and then hepcidin inhibits EPO. So it's like, oh my gosh, it's like, how are we going to fix this problem? So obviously you can't give PO iron to these patients because these patients have a lot of hepcidin flowing around, and hepcidin blocks the GI tract from absorbing iron. So the only option really is to give them IV iron or IV packed RBCs. Okay, and we'll come to find out when we talk about blood transfusion reactions or blood transfusion problems. One of the problems is too much iron, and the iron is going to destroy every single organ system from the head to toe. Destroys the brain, destroys liver function, destroys lung function, destroys pancreatic function. So hepcidin is like, see, I told you, right? But in the meantime, we got to find balance. Like, okay, we'll allow it up to a certain point. So EPO on there can cause a really bad hypertension if you let the count get too high, and also it can cause thrombosis, right? The RBCs get to the point where they're just so viscous it starts clotting off arteries and such. Okay, folic acid, iron, hydroxyureas for sickle cell, and I got B12 up top. These are all, that should make sense. That's going to fix the underlying problem. So polycythemia. So polycythemia is when you have too many RBCs. What causes that? Well, it could be too much EPO. So it was our fault, right? We gave too much RBCs. We stimulated too much RBC production. So that's why EPO is held at what hemoglobin level? No greater than 11. So once your hemoglobin is 11, stop. 11.5, definitely stop, right? But the most common cause of polycythemia is chronic hypoxia. So I have chronic hypoxia, that's going to stimulate EPO chronically, right? So hypoxia is one of our stimuli for erythropoietin. Another one on the list is SNS, or beta adrenergic stimulation. So that's just shortcut for SNS, right? So my SNS fires off when I have hypoxic state, when I have a low oxygen. That's going to fix it down the road, right? And the chronic use of beta agonists maybe could also cause this, but most commonly is chronic hypoxia. There is a genetic variant called polycythemia vera right here. So this is a genetic reason for RBCs to overproduce, right? It has its own certain workup, and there's genetic things you can run to see if they have high RBCs because of their something wrong in the process of making too many RBCs, right? So blood gets too viscous. It's just either way, whether it be polycythemia that's due to genetic reasons or polycythemia due to non-genetic reasons. Your blood gets too viscous and it starts causing thromboembolic events. So it starts clotting off our brain, our heart, right, our limbs, getting gangrenous, right? It can put them at high risk for PEs and DVTs. These patients obviously are more anticoagulation, and we got to get their RBC count down to an appropriate level, or their hemoglobin down to appropriate level. So hemoglobin greater than 18 is usually a diagnostic of polycythemia. So how do you fix that? How do you get someone's hemoglobin down? Just tell them, no, stop it. Huh? Exactly. You're not gonna slice open some arteries. All you're gonna do is gonna call lab and you're gonna say, I need you to come up and draw 250 cc's out of my patient.
Are you serious?
Mm-hmm. Oh. So we get like one of these patients per year, and we draw. You do a The lab comes up and they're like, what am I here for? And like, yeah, I need you to take 250 cc's out of this patient. It's like, how many tubes is that? Right? I don't know. You figure it out. Right? So they pull out like 250 cc's like every day until their hemoglobin is a manageable situation, a manageable number, usually less than 18. Okay? So phlebotomy being the treatment for polycythemia. But we do get those patients usually, it could be a genetic reason, or it could be due to anything that causes hypoxia. That's basically it. Anything that causes chronic hypoxia, whether it be high altitude, like we're training for the Tour de France, right? So the Tour de France is coming up, and I'm going to live up in the Himalayas for 30 days, right? They actually do that for their Everest climbs, right? They acclimate so they get enough RBCs for like 7 to 10 days, and then they can do the next stage of the Everest climb. But or they're going to the Tour de France, right? So that's a reason why I would stimulate more erythropoietin to make me have a higher RBC count. But what else makes me stimulate erythropoietin chronically? Would be due to chronically low oxygen of any sort, right? And most common that'd be like a COPD patient, especially like chronic bronchitis patients, like a long COVID patient, right? Long COVID, someone with like cystic fibrosis or someone with pulmonary hypertension. All these things are going to put someone at risk for chronic hypoxia and like sleep apnea, obstructive sleep apnea as well, OSA. So all these things put them at risk for polycythemia, right? Technically, it's the secondary polycythemia because the primary one was a genetic issue. Okay, so they get this red face, this plethora, right? So this person got fixed. That's with treatment, right? With treatment, they got fixed. So they got this red face because people that are anemic get pallorous. People that are not anemic or polycythemic get plethora, right? Or non-pallorous. All right, so yeah, so they get hypertension, headache, visual changes as that's more blood volume in circulating around. They get really itchy from the breakdown of excess RBCs. Breaking down RBCs also leads to gout. So this RBC turnover can lead to release of uric acid, which can also, especially on the bone marrow side, cause a lot of pruritus. So these are common symptoms. The treatment, again, being phlebotomy. So again, our H&H. What's our H&H for? It measures the concentration of RBCs. So if you have a normal RBC percentage or concentration, technically, of compared to plasma, right? So what is the difference there, right? So hematocrit is going to be our a way to figure out how much plasma to RBC mass there is, right? So someone could be very, very dilute, right? They could be diluted out. Yeah, that could be the reason why their hemoglobin is low. I just put too much fluid in the tank, right? And I get anemic. Or I could truly be causing low RBCs because I have low B12, right? I have low folate. I have anemia of chronic disease. I have low iron. All these things could cause my RBC mass to be low. One of the two, right? And usually we figure it out after day 0. So day 0 in the ER, what do they get? 3 liters of normal saline, right? So they're going to get this little welcome package, and it's going to also have some, has like a blood cultures in there, has a rainbow happening, right? So rainbows, all right? So all those things are going to be given to the patient, right? I keep trying to change colors, but my rainbow is all green. What's that? No, that was before AI made that image. So yeah, so that's a, yeah, so we got 3 normal salines given, and that's going to dilute out my hemoglobin, right? So I'm going to have a hematocrit that is going to be decreased, but is it they truly lose RBCs? I don't know. So that's why I have to trend it from day 1 to day 2. So it keeps getting low, right? I'm really curious, like, oh, hemoglobin 7.8, that's weird. Let's get another one in 6 hours or 12 hours or 8 hours, right? Or let's look at the one tomorrow, right? The one tomorrow is still low, so now it's less than 7. So we will let it go too long. So then now, yes, you need to transfuse if we're less than 7, okay? But if it goes, from a, goes back, you give those fluids, it dilutes out, and then it turns right back to normal, or it's the same, then that's just monitor it, right? It wasn't dilution, it was just dilution, right? What else? So if it starts getting lower and lower, we got to do some more studies and see, is the haptoglobin down? Is the LDH up? Is there a B12 deficiency? Is there a TIBC that's elevated? Is the RDW increased or decreased, right? So we're looking at all those things, okay? So H&H is a 3-to-1 relationship. In polycythemia, we mentioned that they could have a hemoglobin that's greater than 18, Anemia is hemoglobin less than 10-ish, right? So hemoglobin is greater than 18, that's a lot of RBC production. That is polycythemia, right? And you can see dehydration here is just a lack of volume. So if I give volume, that should fix my H&H, okay? What else? So dilutional, that's what we talked about from the ER, right? We got 3 liters of saline, right, on day 0, and we can expect the H&H to come down a little bit because our body has acclimated to that extra saline. That 82% has filtered out into the tissues, right? So we got to look at the trends. We got to look for signs of bleeding because if you are, yes, it could be dilutional, but it also could be someone bleeding. So that's a 2-for-1. We got to make sure we're alert to both of those situations, right? And then someone that has hypoxic, that's a sicker patient, right? Someone's vented with a hemoglobin of 6, that's worse than someone who's vented with a hemoglobin of 9. So because they're vented for a reason, probably because of hypoxia, and if they have low RBCs floating around, that's going to be at risk for further complications. Right? What's the fix? Underlying cause, that's easy. And then transfuse if hemoglobin is less than 7. So cause, we're looking at all the different studies we talked about to see, is there something like chronically we got to fix, or is this something that's like someone that's hemorrhaging in front of me? Okay, so if they're normocytic, it's usually because they're hemorrhaging. If they are macrocytic, it's probably because of B12 folate deficiency. If they're microcytic, right, the MCV is less than 80, then we probably have a iron deficiency anemia on our hands. There's not many other things that cause iron deficiency anemia, or sorry, cause microcytic anemias. I even just equate it in my brain as iron deficiency anemia. Okay, so that's the idea behind anemias. You also get pseudo-anemia with like parasites, right? So sorry, fetuses. That can also cause a low iron intake, but also you have women in pregnancy, they also have a lot more fluid volume compared to someone who's not pregnant.